Welcome. Those people dribbling in, come on, dribble in. I've been asked to say that the audio from the room will be also voiced out in the lobby. So if this feels too claustrophobic to you, you can maybe move out there where there's light and a few seats. And but otherwise, if you're okay, then this is pretty impressive. We're excited to continue the series that we started in the fall of open public forums entitled Transforming Healthcare. About a year ago or so, the board got together and realized that we needed to tell our story. And so that has evolved into this format where once a month we try to have a community dialogue with you about certain ways that Providence interfaces with the changing landscape of healthcare. We've talked a lot about the continuum of care. You'll hear that a lot in the medical literature. It means care from birth through the end of life. And I would say that things that happened at Providence this year sort of has reinforced that with the opening of our Family Maternal Center this summer, and now with our development of a full-scale palliative care practice here in locally in Providence. I'd like to, before I introduce the panelists, I'd like to introduce some of the board members. This was a board project. It wouldn't have happened without our past chair, Martin Byock, who's there. I'd like to acknowledge some of the other board members here. Faye, I see you. And I think Charlie Winters is here. And Molly Shepard, who no longer is at the board, she termed off in December, but she's here because that's who she is. And she's been instrumental in all this happening as well. Anybody else from the board? I also like to acknowledge Christopher Johns, who has come and become our palliative care expert. He's in charge of the palliative care practice in the hospital setting. And Carla, is Carla Davis here? Carla is handling the outpatient palliative care service, which actually began a couple of years ago. My name is Steve Hyro, I'm sorry. I'm the present chair of the, thanks for reminding me, present chair of the Western Montana Regional Community Ministry Board. So we're going to vary a little bit from the format that we've used in the last few months. It's been primarily a dialogue. Sally Mock has agreed to be the moderator of our series. She, as you know, probably know, as well as you know, Ira is the news director emerita for Montana Public Radio. And I told this story in the board meeting this morning that Ira attended, and I'll tell it again. Not that it went over that good, but it's in, you know, when I was moving from Tampa, Florida to Missoula, Montana, 21 years ago or so, people would say, now where are you going? One of those M or W states out there, you know, like Wyoming or Washington or Minnesota or one of those states. I said, yeah, Montana. But there was one lady who we knew pretty well who was actually a family guidance counselor. And she said, oh, I know where you're going. You're going to Missoula. And when you get there, make sure you introduce yourself to this young upstart palliative care specialist who's beginning this amazing thing called the Missoula Demonstration Project. And some of you may remember that from 20 years ago. And some of you may have signed up for advanced care planning even then because of that. So I got a chance to meet Ira shortly after I arrived, and we've interfaced a little bit since then. He's gone on to do great things, not only here, but also in the East Coast. And now we're privileged to have him back in the Providence family for the last year or so, where he heads up. He's the CMO and director of something called the Providence Institute for Human Caring. So what we're going to do is have Ira speak for about 30, 35 minutes or so. And then we're going to open it up with Sally moderating for questions from the audience, questions that she may have come up with over the last couple of weeks or so. And I just want to remind everybody there's some material outside. It may have already been gone, I don't know, but if not, then there's some out there concerning some of the topics that we'll be talking about this evening. So thanks for your attention, and everybody stay cool.
All right. I'm overwhelmed. This is remarkable. In fact, thank you very much for coming. And I just have to just pause for a moment here. Because this is unbelievable. I mean, really. It's amazing. Don't you people get cable in town? Thank you so much for being here. It really is wonderful. I've been looking forward to this for so long. I appreciate the folks at St. Pat's, the board, Steve, Martin, Jeff Fee, everybody who's made this happen. I've come with my wife, Yvonne. Can you just wave over there, Yvonne, who's also just joined Providence as the Associate Director for Education for the Institute for Human Caring. We have been Missoulians since the 1980s. And we were gone for 10 years to Dartmouth, where we were both on faculty, and we built out the palliative care program there, and then left. I'm still on faculty at Dartmouth, but left to come back west because kids are having babies. And I didn't want to be a Skype grandparent. We didn't want to be a Skype grandparents. So we moved back west. We spend most of our time in Los Angeles. Many of you know my daughters Leela and Satya. Leela is now the mother of two sons, about to be 3 years old and about to be 6 months old. And there's darn few places that they would live that we wouldn't live a short drive away. But I now have the privilege of working for Providence at a system level. And hopefully we'll talk about that in a bit, at least in Q&A perhaps, about what the Institute's doing. But we're doing remarkably ambitious things with an amazing support from this remarkable health system. And many of the things that really started or we accelerated here in Missoula, we're now taking system-wide. So we'll talk. Being here is really interesting because I practiced medicine in this town for many years, a couple of decades. I practiced emergency medicine, and I was initially the only hospice doctor in town. I went to the university, and we developed this thing called the Missoula Demonstration Project, which I'm going to talk a little bit more about in a bit. The Robert Wood Johnson Foundation came from Princeton, New Jersey to knock on our door and asked me to direct a national program for them, a grant program. Sorry, I'm just trying to adjust this. A grant and technical assistance program called Promoting Excellence in End-of-Life Care. And so from 1997 through 2006, I and Jeannie Tuig, who couldn't be here tonight, but worked tirelessly through the Robert Wood Johnson Foundation to develop, to build models of integrated, what we were then calling hospice-like care within mainstream health care, in cancer centers, in pediatric specialty hospitals, in rural villages, including Native Alaska villages, Native American villages as well, in correctional facilities, and on and on and on. And what we found was it worked well, and actually in every setting. And it really, out of this town came some leadership in how to make the best of some of the inherently most challenging times of life. And that's what I want to talk about. We live in unprecedented times. Never before in the history of the planet have there been more old people than young people in our communities. I was taught in high school that couldn't happen because of this Malthusian pyramid, right? But it's happening. We're living longer than ever before. Thanks to the miracles of modern medicine, people are now living for often many, many years with diseases that throughout human history would have killed people pretty quickly. When I was growing up, I was born in 1951, so I grew up in the 50s and 60s. In the 1950s, kidney failure was a reliably fatal disease, right? Your kidneys failed, it's a vital organ, and you were, died peacefully within weeks to a month or so. Nowadays, we have several renal replacement therapies. It's a life-changing condition, don't get me wrong, but it's not the sort of fatal condition it once was. Congestive heart failure for all of human history. When somebody's heart failed, they got pulmonary edema, they died. Nowadays, when I was practicing medicine in this town and in urban environments where I practiced, I would often admit 2 or 3 people a day with flash pulmonary edema. And usually within just a few days, they were home, even if I had to put a tube in their throat, intubate them, and send them up to the ICU. Nowadays, people are living with congestive heart failure for a very long time, and for most of that time, very, very well. Cancer. Cancer for, all of human history was a subacute diagnosis. You felt a lump, and within 3 or 4 weeks, whether from bleeding or clotting or infection, nature took you away. Nowadays, we're curing 60% or so of solid tumors. And even for those that we can't cure, many people are living for many, many months, if not years, and for most of that time, very, very well. This is remarkable. It's unprecedented. The problem that we face, of course, is that we have yet to make even one person immortal. Which means that, we still have the challenge of how to care well for people through the entirety of human life. What we have done is invented chronic illness, right? It's an invention of the latter part of the 20th century, and I suggest it's a good thing, but only if we use these unprecedented times to think creatively about how to apply our values, how to apply what matters most to us in this unprecedented world. We make dying hard in America, frankly. Harder than it needs to be. Right? Many people, struggle during the last weeks, days of life, sometimes months of life. We tend to conflate in America disease treatment with medical care, rather than understanding that disease treatment is a component of medical care. And so, it's not an allegation on my part. There's so many Institute of Medicine reports and white papers, blue ribbon panels that have acknowledged that in America, through nobody's ill intention, we tend to make dying harder than it needs to be. Most people, if you ask them where they want to be, how they want to be cared for through the end of life, they'll say home, surrounded by people I know, who love me. And yet, ironically, 70% or so of people die in institutions, either in hospitals, which thankfully is dropping as a site of death, or in nursing homes, which tends to be rising as a site of death. And it varies by region. About 20% of Americans spend days in an ICU before they die, which in virtually every survey, nobody really wants to be. Dying is hard, it will always be hard, but it doesn't have to be this hard. I think one of the reasons that I write and speak a lot is that I think we have an imaginative deficit that if we can imagine a brighter future, I really believe we can achieve it. These days, we can't imagine, first of all, if somebody we love is dying, we can't imagine anything worse than that person dying. But many of you know that there are things worse than having someone you love die. There's having someone you love die badly, suffering as he or she dies. Maybe worse than that even is looking back after the person dies and realizing that much of it was avoidable. On the other hand, many of us can't imagine anything positive, anything meaningful, anything of value when someone we love is seriously ill and might die. But in this room, I know, because I know so many people in this room, I've had the privilege of working with so many people in this room, you know that despite the tragedy and the sadness and the inevitable hard, arduous nature of this experience, there are things that are available to us. Within the human potential, there is the possibility of meaningful experiences during this difficult time of life we call dying. I think we have to imagine, it's just, you know, they say we had to have Jules Verne or H.G. Wells to imagine going to the moon and imagine, you know, some of the great explorations. And I think that's a bit what confronts us now. We can't imagine, either individually in our own lives and family lives, or collectively as a society, as a culture, how could we make the best of this difficult time of life? I've been thinking a lot recently about the notion of opportunity costs. You know that concept? It's an economics concept. And because of the crisis that surrounds how we die in America, and I mean it's always a crisis when you or someone you love is going through it, but also collectively, we know, and the health system knows, policymakers know that there is a public health crisis that surrounds the way many Americans die. Because of that crisis and our appropriate response to it, it focuses our attention. We don't get to talk about what we're missing, the opportunity costs of living fully during this difficult time of life. For some people, it feels unseemly to talk about the potential for positive experience when so many people are suffering. But I suggest that unless we can imagine what's possible, we'll continue to undershoot. We'll continue not to achieve our full potential, individually or collectively. The reason that I tell stories, frankly, is that stories of real people tend to stretch the realm of what we consider to be possible. You know, it gives us a sense of, oh, maybe that is possible. Many of you know a story that I tell a lot. It's a story of a guy I call Steve, not his real name, but he was a real guy. In Missoula, I'm yearning to say his real name, but I won't. A wonderful guy who was dying hard of emphysema. Anxiety mixed with breathlessness. He often couldn't tell which started first, right? Hyperventilating. Steve was a lineman for the phone company, but his real love and his avocation was horse riding. He taught horse riding, did cuttings and taught horse riding. And he taught a lot of young people to ride and to compete. Steve was the quintessential Marlboro man, right? A cowboy, heavy smoker, fiercely proud, hardworking, entirely awful with feelings and communication. A guy in that way. When we met him, I was the hospice medical director. I was called to see him because he was dying hard, suffering. And the team said, you should go up and see him. And I went up and to his home, and I talked to him, and it was clear that his anxiety was overwhelming, causing breathlessness, suffering. And we talked about it. It became clear in hearing his story that Steve had multiple broken relationships in his life, including in his family, that were eroding his quality of life and giving him this sense that things were not okay inside. He was not well within himself. After listening, and we adjusted his medications and used some anxiolytics and a little morphine to diminish the work of breathing and did our thing. He had a 100-foot long oxygen cord where he would pace around the house. I talked to him about relationships and how, no relationships, since human beings tend to be imperfect, you might want to write that down. Our relationships tend to be imperfect, even the loving relationships, and I said that's normal, and but I said I learned a tool for amending and tending relationships and nurturing relationships, and I call them the 4 things, and I wrote them down. They're just 4 sentences, 11 words. Please forgive me, I forgive you, thank you, and I love you. I wrote them on a 3x5 card. Steve said, "Oh, that's really good, Doc. Would you write those? Right. Keep it. Give me that, would you?" And he took it. "Oh, that's just really good." So I'm telling you the story because this was a hospice home visit. I, signed him up for the hospice Medicare benefit, and we did our thing. And this was on like a Thursday. I came back on a Tuesday, and as I drove up, his wife, Dot, was waiting behind the screen door. It was in warm weather, waiting to see me. And as I drove up, I knew something was up because there she was. And she turned around to Steve, who was on the living room sofa, to let him know he's here. Okay? So I walked up, and there he is sitting on the sofa, and they were eager to tell me the story of what happened on the Sunday prior to my visit. And like many longtime married couples, they sort of competed for airtime. Steve was at a disadvantage because he didn't have much air, but so the story as it evolved was that the adult children and some grandchildren come over often on Sundays, and they have dinner, and before dinner this time, Steve, with his oxygen cord and all that, said, I got some stuff I think I need to say, and I haven't always been the best husband and father, and they tell me I'm dying, and I'm on hospice, and I got the morphine. He says, well, and I just want you, I want to say some stuff. And he pulled out the 3x5 card. And by their description, he held it in his hand. And he said, please forgive me, because I know I always haven't been the best husband or father, and I didn't mean it. And I forgive you for sometimes I got my feelings pinched, and I snapped, and wasn't right, and I know you didn't mean it. And thank you for being part of this family, and I love you all. The delivery was a little stiff. But they knew that he meant it, or he wouldn't have said it. Crutch and all, he wouldn't have done it. The reason I'm saying this is it transformed that family. I was in touch with that family for many years. And they frequently told me that this was the best time they'd ever had as adults in their family. There was tenderness in that family that they hadn't known. Now here is a period of time that we would consider Steve to be dying, but the story of his relationships with his wife, his children, changed. And the story of a fractured relationship that ends well transforms all that has preceded. It becomes prelude to a healthy ending. The history of that family changed dramatically for that simple action. We confuse death, the words death and dying in our culture. We talk about a good death. I dislike that term because death is really, beyond life. It's a lifeless state. Yes, it's grammatically correct to say death, to use the term death as that transition from life to lifeless, but in the main, death is beyond life. I don't know anything about death, never been there. Right? Nobody's ever convinced me they know anything about it, to tell you the truth. I know a bit about dying, not because I've been there, but because, like many of you who I know as colleagues, some mentors, I hang out with people who are dying. Have for a number of years. Dying is a part of living, right? Steve was alive. He was dying. I mean, I just signed him up for the Medicare benefit. He was certifiably dying, but very much alive. We have an opportunity in the midst of this unprecedented time in the world, in civilization, to reclaim a part of human life that was inadvertently lost during the middle part of the 20th century. When antibiotics came in and suddenly we were curing infections and surgery got so much better and we were curing so many things that people used to die of, whether it was trauma or coronary artery disease or valvular heart disease or so many things, people learned that the best care was being in the hospital, getting consultants involved, if you were really sick, going to the ICU. And it is for most of us through most of the course of our lives. But since we haven't become immortal, at some point in time, more disease treatment does not necessarily equate to better care. And what we lose, that opportunity, is to live fully, right? We have an opportunity to learn, frankly, from what we've done in hospice and palliative care, and so many of you in the room, to really re-embed the fullness of human life, this notion of whole person, being whole persons, within mainstream healthcare. Let me tell you what I think one of the things we can do within healthcare, one of the things that I, as somebody who works in health systems and teaches medical students and residents can do. At the kernel of quality these days in healthcare is this thing called shared decision making. Now that's changed a lot since I've been on the planet. When I was, growing up in the 1950s and 60s, shared decision making happened when the doctor shared his decisions with you. And it was as if nature itself had spoken. It wasn't as if he was opining. He was just translating the signs of nature. If he said your father is dying, your father was dying, right? If I tell somebody, I'm sorry your father is dying, there's a good chance today they'll look at my name tag and say, who the heck are you? We're not taking this, we're going to Seattle, right? But shared decision making is now the coin of the quality realm. And it means that physicians come to the clinical encounter, clinicians come to the clinical encounter, hopefully expert in the diagnostics and therapeutics, the physiology, the pharmacology, all of this stuff, the genomics, all of that stuff. We patients, or the patients, come to the clinical encounter expert in their personhood, in their values, their preferences, their priorities, their ethnicity, their traditions, their idiosyncrasies, right? And together, in a partnership, we clinicians can help apply the very best of medical science in a manner that provides the best chance for physiologic outcome, but consistent with the values, preferences, and priorities of the people concerned. So often in teaching medical students, we conflate illness and caregiving and dying as being fundamentally medical experiences. They're not. They are fundamentally personal experiences that have obvious medical aspects to them. So I suggest that with shared decision making, expecting that quality really will require a conversation or multiple conversations in partnership giving people the very best chance of disease treatment and cure, life prolongation, restoration of function, but also with full attention to their physical well-being, their emotional, their interpersonal, social, spiritual well-being. We can do this. It takes some preparation. We have to have the conversation. It takes a functional healthcare system. Oy vey. And I don't mean this one, you know, here we are in Missoula with a superb healthcare system. But nationally, we know that our healthcare system needs, you know, reformation. And we're doing that. We'll come back to that, I hope. It takes a family. You know, and I mean family as a verb, that word as a verb. Not by family membership by bloodline or marriage alone, but by that phrase, for whom it matters. So often, those of us who work in healthcare see that the aides in long-term care become family for frail residents. Our neighbors so often become family. Our coworkers sometimes. And it takes a community. And community also is a verb. You know, it has the substance of a noun, but it's all about mutuality, mutual responsiveness. In a community, your well-being matters to me. And hopefully my well-being matters to you. People, I answer email from several websites, and not uncommonly people have asked me, Dr. Byock, I'm in my 60s, I don't have any children, or my children live in a foreign country, and I'm aging, you know, basically alone, and I'm wondering, I've read your stuff, and I'm wondering in the future, how can I best prepare for my own aging and frailty? And, you know, my usual answer to that is, well, get yourself a family. If you're fortunate enough to have a family, this is a time to really reinvest in it. Because in a family, people are responsive. Their well-being matters to one another. You know, if you don't have a family, I'm not suggesting that you get married or adopt somebody. Not that those are bad things, but, you know, it may be a little too late to. There are websites. But if you're not going to do that, then get yourself a community, right? You know, and it could be a faith community, a vibrant faith community really matters to one another. If somebody doesn't show up, they check on them. It can be a workplace community. It could be the 4-H or the Lions or the Elks or, you know, a service group. And of course, it can be a geographic community. I'm going to quit soon, I promise. But in the 1996, 97, 98, through the early part of this century, we, in Missoula, Montana, created something called the Missoula Demonstration Project. And basically what we said is, what would it be like to live in community with one another rather than merely in proximity to one another around illness and dying and caregiving and grieving? And there were committees and work groups across the spectrum of the professions and the vocations. Yes, we had doctors and nurses, but we also had a group of the Western Montana Bar Association. We had school teachers. We had a ministerial leaders committee. We had faith-based other faith-based committees. We had EMTs meeting. Funeral directors had a vibrant group. They did, though, actually. Sorry, pun intended. I mentioned school teachers, and it was something else. And we did it in a quasi-academic way. We were funded by several national organizations. We had a wonderful board of directors. Lily Tucholsky's here somewhere. Lily. There she is. Hi, Lily. Laura Millen was very much involved. Jeannie Tuig, multiple members of the community. Larry White was involved. We got national attention. I'm going to pass some of these out. I just dug these up from my files today. This is from Modern Maturity, which became the AARP Bulletin. 35 million copies of this article was printed. Just pass that around when you get a look at it. This is Tom King's face over here. This is Tom King's face now. This is from 2003, a supplement in the Missoulian that is called Our Lives, Our Choices. I'll start this over here. We'll start passing these around. I don't have enough for everybody, but I'm getting rid of all the, I'm solving several problems here. Here you go. And we were getting national attention. It was remarkable. There was in November of 2000, let's see, November of 1997, All Things Considered did a full hour on Missoula, Montana. I think it's still online. Think of that. And people were starting to say, you ought to see what they're doing in Missoula. Because we were a community showing up to take care of one another. Can I get your help to start passing these out? Here you go. There's about 100 of these. This is I'm not being self-promoting. I mean, what would I promote? You're already here. But this is an editorial I wrote for the Missoulian in April of 1999, talking about how, as a community, we're showing not just healthcare leadership, we're showing social and cultural leadership, right? So that's what I want to talk about. Mike, would you just hand some of these out? Somebody else? Can I get a? Thanks. Here you go. Because if this is personal, not just medical, then illness and dying are part of our lives, our individual lives, our families' lives, and the lives of our community. We're a diverse community, even in Missoula. We're a highly diverse community. And we've got different politics, and we've got different religions and outlooks. But the great equalizer, if you look at across even the most politically charged issues, are natural disasters. Hurricanes, floods, famines, avalanches up in the Rattlesnake. I mean, when it happens, when it's hitting the fan, people don't ask who you're going to vote for, right? Are you a social conservative or a social progressive, right? We just reflexively respond to the commonality of the fact that we're all in this together. Despite our diversity and serious differences in some issues, I would submit that illness and dying are the natural disasters that await us all. On this, at least, we can live our values, which are that we matter to one another, that we care about one another, and that we care about this community. I stand here not only as a physician and nowadays an academic and part of the Providence Health System, but as a once and future Missoulian, somebody who is likely to age here and die here, somebody who cares a lot about this community. And I think we have an opportunity to reinvest in making this place as good as it can be, to ensure that people are cared for, that we give the best of medical treatments, but that we acknowledge that all of us here are wanted, worthy, and dignified through the very end of life. We've done things that are groundbreaking before. Missoula Demonstration Project was groundbreaking. The Chalice of Repose was groundbreaking. So much that's come out of this community has really reset conversations. I think it's still Missoula. And we still have a chance to, as a community, think creatively together about how we can make the very, very best of these inherently difficult times of life. So that's what I came to share. And I think it's time to open up to discussion.
I think so
Thank
too.
you all again.
I have so many questions for Ira, and I know you all do too, and we're going to get to those. I get to ask the first one. That's my prerogative as a moderator. But then we're going to go to the audience, and what you need to do is just raise your hand, and I will acknowledge you. We do have microphones that are circulating, and we do want to use those so everyone can hear what your question is. So get ready. My first question for Ira is, you've been talking about this for a long, long time, Ira, and you've said the discussion has lost momentum. It's lost it in Missoula, it's lost it nationally. What's going to get it back to being the kind of discussion you want to have, and what is it do you want people here to do when they leave?
I want to challenge the premise because I think it has languished for a long time. I don't think it's languishing now. I think the conversation is very active in America now. Looking back over the last couple of years, the conversation has heated up. I'm a bit concerned about the direction of it a little bit, and I'll come to that. But given everything that's happened with the assisted suicide movement and Brittany Maynard, with Atul Gawande's book, which just skyrocketed as a bestseller, boy, I could go on and on, the new Medicare regulations for advanced care planning, which have been a long time. That was the death panel thing that got taken out of the 2009 health reform law, but it's now been passed and is in force through regulation with virtually no controversy, by the way. It's really remarkable. So there's actually, I could go on and on. The Journal of the American Medical Association's just spent an entire issue talking about end-of-life experience and care and palliative care. There has been dips, but I think it's an active conversation. My concern is that we're still seeing illness and dying almost exclusively through the lens of medicine. Like this is a medical issue. This is, the fascination with how doctors die. There was a friend of mine wrote a little essay in Zocalo that went viral, and boy, millions of people have read that essay about how doctors die. Now there's studies about how doctors die, but it's all about their choices about medical care. If I had more time, I'd read to you from some quotes from physicians that I know, some published, some not, who talk about how they chose to live while they were dying, which is actually a different topic. So look at the personal aspects of this time. So I think it's almost a cognitive rut in the road that we keep thinking it's about medicine or how much medicine and all that. If all we do is improve medical care for people who are seriously ill and dying, the best we will achieve is a better medicalized dying experience. Not yet what we can do. So I think there's that. And I think we also look at dying and we think it's either suffering or it's avoidance. And again, I would say those two things are important, but there's also this opportunity to live fully. To the next big thing, I hope, is acknowledgement and exploration of the human phenomenon of well-being during the very last stages of life. Because that's anthropologically possible. That's not a woo-woo statement. Right? That's verifiably possible. And as a culture, frankly, it's still something that we need to incorporate into our mindset of full and healthy living.
There have to be people in the audience who think that might be a woo-woo statement or have something else they want to ask Dr. Byock. So please raise your hand, and yes, that gentleman over there, and wait for the microphone if you don't mind. She's coming this way. Thank you.
Dr. Brock, is there a need to legalize assisted suicide?
Well, you know, from my perspective, no. But it is legal in Montana. It's effectively legal in Montana.
It's not legal.
I understand. It was,
It's still a homicide in Montana.
well, the Supreme Court seems to disagree.
The Supreme Court did not vacate the lower court's ruling that was a constitutional right, and they said that a doctor could, if he's charged with a homicide, he could use consent as a basis of defense. So, you know, no one has immunity in Montana like Oregon and Washington. So it's not legal here, it's a homicide.
So, you know, I've opined about this in print a great deal, and you can read my papers. I'm really focused on making the best of medical care, making the best of people's quality of life, addressing their not only their current suffering but their fears. You know, from my perspective, even where it's legal, it's not medical. In California, it's now legal, and I acknowledge that. But from my perspective, it's not a medical act. So I'm still focused on making medical care the best it can be. We have a lot of work to do just to do that, and that's where I'm focused my attention.
Can you summarize, though, Ira, what your specific objection is to legalizing physician-assisted suicide?
Well, I never do well at summarizing this, but
I will make you.
you know, my attitude toward it is I come at this as a proud, lifelong political progressive, and I think that that we have basic social responsibilities to human beings, including to take good care of them through the end of their lives and support their families. In America today, we have a public health crisis that surrounds the way we die. People are dying badly. We know why. The Institute of Medicine has published no less than 6 reports about the causes of people suffering through the end of life. We're not teaching medical students or nursing students even the basics of caring well. We're graduating medical students these days with degrees, MD degrees from some of the best universities. I get to meet them as residents. They will tell you that they haven't been well trained to have these difficult conversations. They're not skilled in even symptom management. We have a healthcare system that makes paupers of people for being seriously ill and not dying quickly enough. People are sent to nursing homes that are staffed woefully, shamefully low, so that there's not enough aides to answer the bell when they need to get up and get to the bathroom, so they lay often wet when they need to be changed. They are reliably made to feel undignified. In this context, in this world, to legalize physician-assisted suicide feels to me to be a capitulation to failed social responsibility and a retreat from our basic human responsibilities. Now, I argued strongly, and I published several op-eds in major papers around the bill that's now been enacted in California, and I lost. We lost, but in the stroke of the pen, when Governor Brown, made that legal, he gave physicians authority to write lethal prescriptions, but there was not one iota of change in medical education, in licensure, in the requirement, in any sort of requirement for hospitals to have palliative care programs, to improve staffing in nursing homes. So with a stroke of the pen, we made it legal, but we didn't address any of the sources of suffering. From my perspective, that's not good governance. It's certainly not good social policy, and so from a civics perspective, this is not the way to address a public health crisis. That's my major objection.
Okay. Other questions? Yes, back there. And wait for the microphone. Yeah.
Thank you, Dr. Byock, for being here. My question is, in your vision of the whole person care, how do you see a hospice team or a palliative care team functioning as a whole. So what kind of revisions do you see in the care of staff in their abilities to care for patients in this way, in this community-oriented way, rather than maybe the problem-based
Sure.
model or however?
So, you know, people who are seriously ill have more than needs for diagnosis and treatment. They have needs for pain management often, for dealing with other symptoms. You know, much of palliative care, as you well know, has to do with pain in the bowels, right? That's where people live. But also, you know, nutrition, skin issues, you know, sleeping, you know, function, all of that stuff. And that's not trivial. And for many people, certainly people with, you know, advancing cancer or congestive heart failure or other neuromuscular diseases, COPD, on and on, that really requires some expertise. It's not expertise that many other disciplines can't have, but having a palliative care team that does this day in and day out is key. At the core of palliative care is this notion of communication and matching achievable goals with people's, you know, preferences, their choices. That too needs to be disseminated across the health system. And so I think that the palliative care, having palliative care embedded within healthcare in general, both helps seriously ill people live as fully as possible, as well as possible. Working shoulder to shoulder, palliative care team and oncology team, or palliative care team and cardiology team, or critical care team is a match made in heaven. Because while one team is focused primarily on the physiology and treatment of the disease, another team can be focused primarily on people's, you know, physical well-being, their emotional, social well-being, spiritual well-being, and their families. I think that, though, that palliative care these days, and what we're trying to do within this large, you know, 35 hospital Providence Health system, is to also be agents of change, to be the boots on the ground, educators locally, we're putting in place a number of quality improvement initiatives. It takes people on the ground to teach our colleagues how to use them. And so we actually have, palliative care these days are also change agents, teaching sophisticated communication techniques, sophisticated symptom management techniques, but also the systems change that is needed to refocus or broaden the focus in healthcare from just looking at the problem list to understanding that people's well-being and their families' well-being are addressable concerns, and the outcomes there are even measurable. Now, what gives me hope with all this, by the way, is that there's been, or we're in the midst of a tectonic shift in the way healthcare is financed in America. It started with Romney Care. It did. It became Obamacare. And now it's really embedding itself within, was in the doc fix legislation, and Medicare's given announcements that it's gonna move from volume to value. From the bottom line in healthcare is no longer just how much you charge and how many procedures you can bill for, but what the measured quality outcomes you are achieving and can document. And so that's a big shift. And it also is a shift toward population health rather than just the health of individuals. So suddenly and increasingly, if you have an elderly couple, Harry and Shirley, and Harry's the one who's fallen and broken his hip, Shirley's well-being matters too. It always has. But now, increasingly, within population health models, it actually measurably matters. And again, palliative care is instrumental in making this shift. What I want people to leave here with is, but it's all of our responsibility. You know, if we don't know what to ask for, if our expectations aren't higher than just getting good diagnosis and treatment of our disease, that's all we're going to get. Because healthcare, as good as it is, as wonderful as the people in it who create it, who comprise it, I'm one, as well-intended as we are, it's an industry. And the profit motive is alive and well, and financial pressures are alive and well, and the productivity expectations. So we have to, without a citizen consumer voice, we're not going to achieve what we can, and those opportunity costs will go unfulfilled. Think the birthing movement. You know, when we were having babies back when we boomers of a certain age were having babies, we transformed the way pregnancy and childbirth were approached. It went from just being a medical problem, right, to being a highly personal experience of the woman and her partner and family that simply required expert medical attention. And within 15 years, we transformed pregnancy and childbirth. You know, when I was growing up, I was born under general anesthesia. Right? When I was growing up, they didn't let fathers in delivery rooms. It would have been outrageous. By the time I was delivering babies in my family practice, we were worried if the father wasn't in the delivery room. What's up with that? Is there a problem? You know? Right? That's sort of what needs to happen. And oh, by the way, the measured outcomes, health outcomes of prepared childbirth after La Leche and Lamaze and all that were significantly, substantively better than the measured outcomes of unprepared childbirth. So medicine got on board and it became integrated, and now it's just mainstream medicine. Exactly that shift needs to happen in serious illness and certainly the care of people who are dying.
Okay, we have a lot of people who have questions.
I'll keep it short.
Okay, gentleman in the back there.
Thank you. Dr. Byock, thanks for being here. It's a pleasure to see you again and hear you. One of the questions that I've got is about, with your idea of community, moving from St. Pat's to community to St. Pat's as a patient is moved around, better or different care regardless. One of the things that I've heard about throughout this entire community through an experience I had was about continuity of care. But what it turns out, continuity of care, at least I've learned the definition to mean, as long as I'm working with you as a doctor, the continuity of care is there, and as soon as we go to Sally or to whomever else in the room who might take care of someone, they also provide continuity of care which does not match yours at all. So how do we as a community come together and get the needy person's needs met and maintain that continuity of care?
It's a great question. I think we missed an opportunity, by the way. I was gone for 10 years at Dartmouth. I came back and found out that both hospitals had adopted electronic medical records, and they adopted different electronic medical records. What the heck was that about? And where was the uproar? So let me get on my soapbox for a minute. These are difficult pieces of software to use, right? It is not easy. Learning an electronic health record as a physician is not trivial. And you have two hospitals now in the same town where it's as if one speaking French and the other speaking German, right? And where was the uproar? Where was the Missoulian? Where was MPTR? Where was the city council when that was happening? You let healthcare make this decision themselves? Are you kidding? I mean, really, this is not okay. This was, from my perspective, maybe I'll be wrong and you can argue with me, but I don't think this was responsible from a community. But we were missing the citizen consumer voice here. And that's damaging. So something ought to happen around that, because you're absolutely right. We are creating structural barriers to continuity. You could imagine a community in which, even if they were competing hospitals, they entered memorandums of agreement or contracts to share medical records, because this is a geographic community, right? That's what could have happened. So I don't have any quick fixes for this, but I think it's a real problem. And I think we need to be active as people living in this community, not simply turn this over to healthcare.
The woman in the pink.
Thank you for being here. We really appreciate it. You kept speaking about going away from the medical train of thought when we're caring for end-of-life patients. And as a medical professional myself, I'd like to know, how do we better enunciate what that care means when we're advising patients whether they should seek that maybe advanced care that would end them in the ICU. What that means, you know, talking beyond intubation, you know, central lines, pressor drips, all of those things that extend life but also can cause a lot of pain at the end of life. How do we better have those conversations to help our patients be on the same level as us, you know, without going to school? How do we enunciate that?
Thanks for your question. In general, I think in addition to doing the diagnostics and therapeutics and being scientifically crisp and really, you know, making use of the real gifts we've been given in this unprecedented times in healthcare, we need to, in addition, or maybe instead of asking people what's the matter with you, or, you know, asking them what matters to you, refocusing on the personal. One of the things that, one of the really exciting things that we're doing with the Institute for Human Caring is we actually have launched a quality improvement initiative across Providence that includes embedding something called a serious illness conversation guide within the electronic medical record. This is a 8-item conversation guide that comes out of Atul Gawande's lab at Harvard, the Ariadne Labs. It was created by Atul's and colleagues of mine, Susan Block and Rochelle Bernanke, palliative care doctors. And it actually is a simple kind of categorical guide for interviewing people about their biggest concerns. Starts with, what's your understanding of your illness? How much do you want to know about your illness? You know, unless they say, I don't want to know anything, talking about what I understand as a clinician about where you are in this illness. And then, you know, if things don't go as we hope, if things get, you know, progresses instead of getting better, or when eventually things are, you're in a waning phase, what would you hope for then? What would be most important to you then? What do you fear? You know, are there things that you wouldn't want to live without in terms of capacities to get up and around or to communicate with people? Are there some things that are absolutely things that you are confident today you wouldn't want to live without, even though we'll continue to have these conversations? Are there trade-offs? Would you be willing to come back in the hospital if there was a chance of living a little longer? You know, how much does your family know? How much do you want them involved? Are there people in the family who you don't think should be involved in your decisions or your care? It's a simple tool, but we've tried to make this, these are things we know that doctors have difficulty talking about. And frankly, as a medical educator, I can tell you, medical schools around the country are not doing a good enough job teaching doctors how to have these conversations. It takes more than a lecture. It takes several days on service, you know, in rotation on a palliative care service. It takes having standardized patients, meaning actors we train up to act as patients, so that in a mentored, supportive, private environment with master educators, medical students and residents in training can learn how to have these conversations, to feel those words coming out of their mouth. What we're doing in Providence is now, we're doing this as CME. We're teaching doctors, hospital medicine doctors, critical care doctors, as well as primary care doctors, to have these conversations. Using a charting tool, we put in the electronic medical record. It's easier to have the conversation, easier to chart it, and we can now find these goals of care conversations. That's just one way we're trying to make it easier. We're also beginning to, we've opened a national contract with a national vendor called ACP Decisions for patient education videos, little 3- and 4-minute videos about things like what is advanced care planning? What's an advanced directive? What's goals of care? You know, what's CPR? All of this comes from Angelo Volandes, who's written a lovely book called The Conversation. He's gotten a lot of attention. He's been featured in The Atlantic and several other New York Times. And now, across the Providence system, these videos are available free of charge. They're very expensive it's an expensive contract, but they're now free for clinicians to begin to work into their practices so that before you have that serious illness conversation, maybe a patient has seen a video about advanced care planning and about advanced directives or CPR or whatever. So we're trying to make the right way the easy way. But we're not retreating from and we're being pretty explicit that quality of care requires these conversations. There's no shortcut. It's not ancillary. It's requisite to quality.
Other questions? Yes, yep.
You kind of answered what I wanted to talk about.
Can you wait for a microphone? Sorry, so everyone can hear you. Thanks. There we go.
So you kind of answered the question that I wanted to talk about as doctors. I'm a hospice nurse. I've been a hospice nurse for over 10 years now. And the elderly people that I take care of, I'll say 70 plus.
Thank you.
Doctors in their eyes know everything. They follow the rules. They don't deviate from whatever they tell them to do. If they say they're going to be okay, they're going to be okay. Doctors need to have the training from the beginning so they can have these conversations from the beginning when the person comes into the office and say, this is what, whatever you need to say to them, to get them thinking about how life is going to be, because they're scared to death. By the time we get to them, it's terrifying. And people my age and younger, 60 and down, we're too bold. We voice our opinions. And the elderly people, they don't say anything. They're afraid to say things because the doctor knows best. And that's what I feel needs to happen. The doctors need to start the conversation.
Well, it's one of the things that needs to happen.
To me, it's a big one because I hear it a lot.
I understand. Everybody has the one thing that they think needs to happen. The doctors would just refer to hospice earlier. If the insurance companies would just pay for, it's all true. It's all true. And I'm here to tell you that without an active citizen consumer voice and higher expectations, none of this will come to pass.
Yes.
We have to grow the rest of the way up, right? You're gonna die. Get over it. And let's get on with living as fully, as vibrantly, as joyfully as we can together. The most pure wisdom I know about going through hard times is do it together, right? That's the best thing I can tell you. Mike.
This is not a frivolous question. I'm channeling Norman Cousins here. I'm wondering what role laughter and humor have to play in this process, if any.
I think they have a lot. I kibitz a lot in my medical practice, for one thing. It's just part of what I do, and I tease patients sometimes mercilessly. I do it for them, actually. I think friendship, real friendship with patients, is really a wonderful tonic. And people say, well, how can you do this? Doesn't it burn you out? Doesn't it drain you? Well, yeah, but it also fills you up. In the authenticity of relationships, you're filled up as well as drained, right? It hurts, it's painful, but it's also enlivening, joyful. So I think laughter is, laughter's great, music's great, children, amazing. If it required a drug to elicit the sort of response that happens if you put an 8-month-old baby in a frail person's arms, the FDA would say caution may be habit forming. Right. Dogs, puppies are great. All of this stuff, this is soulful stuff, because these are times of life. I'm a big one for people telling stories. If you want to know what to do with somebody, you're not sure, get a picture album. Get a little MP3 recorder, or now your smartphone, and just go through the picture album and ask them, interview them. One of the things, by the way, that we're doing through the Institute for Human Caring, I almost forgot to say, is we're just signing a contract with the National Story Corporation. So it has to be built, but we will have across Providence a story bank to collect stories of patients and families, stories of our caregivers, in the human acts of caring well for people, not just about end of life or serious illness. I hope it will be about cardiovascular health and women's health and sports medicine as well. But you have a chance in this campus to build a Providence St. Patrick story bank to collect stories from the community. How cool is that? Right? Because we matter to each other, and stories are part of re-ensouling healthcare with the stuff of human experience.
And we'll take a question over there. And the microphone is coming.
Really not a question. I just have a thought. I think the thing that would be wonderful is if we could go out to different agencies and let people my age and older, and even some younger people, that it's okay to ask the question and have them know what questions to ask. It's forums like this that give us the ideas of what to ask, and it's having further meetings that gives them the courage to ask the questions. The other thing that I hear a lot in my community is that people go to the doctors by themselves, especially when it's something important. We need people who would volunteer to help and go with and either help with the questions or take notes or do whatever, because when you're hearing even good news, you don't hear it all. You hear part of the answer. And it would help to have people go with you on doctor visits. And I don't know how to make that happen, but we also need to know the questions to ask.
Thank you. Mm-hmm. So one of the other organizations that I'm active with, and that the Institute for Human Caring is working within Providence, is something called the Conversation Project. You know about that? Ellen Goodman, the Boston Globe columnist, has created this Conversation Project. You can look at it, theconversation.org, or conversationproject.org, I think. And there are conversation starter kits. They're democratizing having these conversations around your kitchen table. She said, we want people to have these conversations where they live, work, and pray. Except for those of us in healthcare, that's not healthcare. But at least conversations about clarifying your values, what your worries are, what your hopes are, what you aspire to, what you'd want other people to know, who you'd want to speak for you, right? So there's, that's one of the ways, and there are wonderful, if you go on the Conversation Project website, you'll see testimonials or just stories from first-person accounts from people of all ages, including very younger people. This is just, we're trying to normalize and advance the culture in making these things normal.
Yes, microphone right there.
Thank you again for coming. I agree with most of what you said. However, I'm hearing a bit of a disconnect in that if we're looking at the patient or the person that is living well at the end of their life, and you're asking them what matters most to them, and one of the things they say to you is, it's important for me that I have my dignity. It's important for me that I'm able to care for myself. It's important for me that I'm not incontinent. And it's important for me to know that I'm the one that says, I've had enough, I'm done. And I want to have that autonomy. So I'm hearing a little bit of a disconnect without people having the option to have aid in dying.
What can I say? I'm not here in any way to convince anybody that around this issue. I know that there's certain humility, and I probably sound arrogant to you, But there is a certain humility to being a doctor. There are only certain things that we're not all things to all people and shouldn't be. And in real humility, I think there are some things that doctors must not do. We're not supposed to treat people for our personal gain beyond the wonderful salaries that we make, right? What we can't have, if they want to give us their Lexus in their, will, it's really not okay. Really not. We don't ask people for money for our favorite charity while we're being a doctor to them, right? We don't have sex with patients, even when they want us to, even when we want to. I'm not really kidding here. There are some things, it's normal, it happens at times where people get, fall in love with their doctors, and doctors may feel the attraction. I teach medical students that's of diagnostic significance. Something's happening that's interesting there. But it's not the feeling that's not wrong. Acting on it, not okay. And from antiquity, doctors are not supposed to kill patients. As a corollary, let me say, there are times when a doctor in active practice in critical care and pulmonology, cancer care, and palliative medicine may want to kill a patient. I mean that, because we can't imagine what else we might do. I would submit that that's why we work in teams. That's why we have palliative care teams to call up and say, hey, I'm stuck here. I can't think of what else to do. And sometimes when we can't imagine what else we can do, the limit is not in our capacities, but in our imagination. We may be unable to imagine what else we might do because we weren't trained in this syndrome, we're not good at existential suffering, we need help. But there are limits built into the fundamentals of the profession. We were given remarkable privileges to be part of people's intimate lives, to hear secrets, to touch people in very highly intimate ways, to see them unclothed. With that came boundaries, right? No personal gain, no sex, no killing. Along with that, we don't torture people. We're not engaged in enhanced interrogation. Even when a policeman says we need this, or a general, I order you to do that. Throughout history, the profession has stood aside, said, nope, not us. We don't engage in capital punishment. We don't do it. We're not executioners, even where it's legal. So there are limits to what physicians can do. I could envision, as it is in some places, where it's segmented. The euthanizing or the assistance in suicide is segmented within the profession or to another profession, which at least leaves physicians focused on caring well for people. But I submit, here we are talking about this, but I understood, and you might correct me, that it was settled in Montana. So let's talk about something else. I'm not here to roll that back. I'm here to make the best of what we can do to care well for one another. It can be legal. I hope to make it unnecessary. Frankly, I hope to make it irrelevant in the lives of people. That's what I think is our opportunity here. So.
Question in the back there.
Hi. I don't have a question. I want to thank you, actually. I'm a member of the disability rights group Not Dead Yet. We've been fans of yours for a long time.
And mine of yours.
And when I moved here with my husband in 1998, it was not too long after that before you went to Dartmouth. What I didn't know then is that the seeds that you would plant at Dartmouth and that you would nurture there and would spread throughout that area would benefit my brother who died 3 years ago of cancer in Vermont. He received his oncology care from Dartmouth Hitchcock, which was infused with the Byockisms or Byockology. And those folks worked with the Brattleboro Hospital and the people he had there that were immediately there if anytime he needed anything, and the local hospice group. He was able to die in his own bed, in his living room, looking out the window at the woods that he loved, because there were people in that community who loved him, who would come and sit with him, who would rub his feet. I was there every couple of weeks helping him settle his affairs. And I don't know that any of that could have happened without what you did when you left here and you went there, and I just wanted to thank you for that.
Oh, thank you. Thanks. Can I wedge in one comment?
Sure.
I just don't want to lose this thought. And there are many people in this room that I know that were deeply involved in Missoula Demonstration Project. We became the Life's End Institute. And some of you will remember, some of you who were on the board or early on in planning committees, there was Kent Ellsworth was part of our board. He ran Meals on Wheels, I think, for years. And one day we were in this strategic planning retreat, and we were thinking broadly. We're thinking, well, what would success look like? That's one of my favorite strategic planning questions. What would success look like? If we were actually successful 5 or 10 years from now, what would it look like? And Kent, I know, he said, success would look like the teenager on his way home from school, stopping on his bicycle to check on the frail elderly lady who lives next door. Not because somebody who told him to do so, but because not checking on her wouldn't feel normal. Yeah, that's it. Where the new normal is, this is just what we do, because it would be odd not to, right? That's, so what does that mean for leaving here? I'm not sure, because there's so many actions. I guess what I want is to influence people's expectations so that we think about life as a connected experience, that we belong to one another, that this isn't contractual, it's more covenantal than that. And that we, that we check on one another. I would say, if you're worried about somebody's privacy and worried about being too nosy, but you haven't seen them in a while and you think they're ill, I give you permission to be nosy. Tell them, I heard this guy, I can't remember his name, but I heard him once at St. Pat's, and he said, check, right? Show up. You can always apologize. Right? But, we belong to one another, and reinvest in this community.
Another question over here. Yes, sir. Wait for the microphone.
The transformation of healthcare and the treatment of whole people, do you see the role of spirituality increasing? I'm a hospice chaplain and a hospital chaplain, but it seems like we're not viewed yet as a really cog in that IDT. And I think it's going in that direction, and it does have a big impact.
So I think chaplaincy needs to be a vibrant part of interdisciplinary teams and healthcare teams. I learned a lot about chaplaincy from my friend Tom King here, who just he didn't get the memo that you're supposed to be quiet at team meetings, and has functioned, and I'm sure still functions as a full partner in the clinical dynamic. I think chaplains say this a lot, but often I'll go to meetings and they're very quiet. They're experiencing the experience, right? But we need them to be active in, seeing patients, writing in the chart, using terminology that is broad enough so that the other team members can understand it, and asserting themselves, and I don't mean to say that you're one at all, John, but asserting themselves as full members of the team. That's important to teach the teams that how much you matter, how much you can bring to the table, that the human condition is inherently spiritual. We are inherently meaning makers. It's not a mistake that every culture across humankind has created a spiritual, tradition. And that's because it's part of who we are biologically and anthropologically. So I think it's past time that chaplains stop asking permission and being reticent to speak up. It's time to really own the fullness of that discipline as well.
Who wants to have the last question? Yes, this young woman there.
Basically, I want to know what happened to that demonstration project. When I work with people who are dying, one of the main reasons I do that is because that's a way of feeling more alive. And I also realize that the people that I'm working with, I see them being more alive and having a richer life than when they were living. It's like that whole thing of like being able to live fully before you die. And it sounds like that demonstration project and what you were doing here in Missoula was doing something very broad. What happened to it? How could something, was it just because money dried up? I mean, why if there's a real community, why do you need money?
Well,
I mean, really, but I mean, it sounds like you laid the groundwork. Why didn't it continue? I'm sorry.
In real communities, people have mortgages and grocery bills and everything else. And indeed, a significant, I don't know that it was I don't want to say it was the entire cause, but I think the money did dry up. We were grant supported, and we made good use of that. We published a lot, but it would have required continuing to write grants and to compete in an ever more competitive environment where grants, frankly, were drying up. We never kind of made the leap to a different business model, if you will. I was hoping that the Missoula Demonstration Project would, and now then the Life's End Institute would be embedded within the University of Montana, where I thought it ought to go, frankly. But that didn't make that transition. I would simply say that, like the story I told of Steve and so many others, a story that ends well changes everything that has preceded. Maybe it was just dormant. Maybe it has an opportunity to rekindle here in committees that are looking at how we can live. The organizing question I would give you is, how can we live in community with one another, rather than merely in proximity to one another, around illness, dying, caregiving, and grieving? It's an open question. So, that's a question for discussion in faith communities, in workplace communities, even in schools, service groups, as well as within healthcare. I do everything I can to support that conversation. So can I just say thank you all again for coming?
Yes, thank you all, and thank you, Ira. Thank you.
Thank you, Sally.
Thank you so much. Yeah. All right.
Sally and Ira, thanks an awful lot. Thank you all for coming and staying for the whole time. If you have any questions about this program or future forums, as a matter of fact, February 16th, because of Heart Month, we're going to have a forum here, same format. Sally's going to be here with some expert panelists from the Heart Institute talking about the healthy heart, preventive and rehabilitative care. So you're invited to come back. Like to match the crowd, that'd be great. If you have any questions about this presentation or any future forums that we have planned through May, you can go to info@stpatrick.org and get any information you need. So thanks again for coming, and drive safe home.
Let's go south.